recording. طيب بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيد الخلق أجمعين سيدنا وحبيبنا ونبينا محمد. السلام عليكم ورحمة الله. We continue our series of breast lectures, Mammographic Approach, number 8. Today we are going to discuss the evaluation of mammographic masses systemically using the mammographic lexicons. Okay, to mammographic reporting. What are the mammographic features of breast cancers? Are you hearing
asymmetry? Yes.
Asymmetry?
Asymmetry, classification, architecture distortion. Mass asymmetry, architecture distortion, classification.
Asymmetry, architecture distortion, classification. What else? Mass. What else?
Associated features.
Mass, asymmetry, microclassifications. What else? Architectural distortion. What else?
Nibble changes.
Nibble changes. What else?
Skin changes.
Edema, yes. Skin changes and axillary lymph nodes. Okay. So the report organization, as we described it before, including first item, indication for the study, and then the succinct description of overall breast composition, A, B, C, and D, discussed last lectures. And the third item, which is the clear description of important findings, that including mass, asymmetry, calcification, distortion, and associated feature. Today we are going to discuss number 1, the mass, and then the report include comparison to the previous, concluding into final assessment, and give management accordingly, and then communication with unsuspected findings with the referring physician. I don't know, there is technical problem in my computer. Okay, so mammographic lexicons, as we describe, the breast composition, and then the abnormality, including the mass, and the descriptor for the mass is shape, margin, and density, and each descriptor has sub categories like the shape described by oval, round, irregular, margin circumscribed and obscured, microlobulating, distinct, speculated, density, fat, low, equal, high density, and the asymmetry, as you know, asymmetry, focal, global, developing, architectural distortion, and when there is distorted parenchyma without visible masses, and the calcification, as you know, described by morphology and distribution. We are going to discuss in details later. And then the associated features: skin changes, retraction, thickening, nipple changes, also retraction, thickening, axillary adenopathy, architectural distortion, and calcification can also considered as a main abnormality or can be considered as an associated feature. So today we are going to start with the mammographic abnormality. And as we mentioned, the abnormality could be asymmetry, calcifications, architectural distortion, intramammary lymph node skin lesion, solitary dilated duct associated features, But today we are going to start with the first important finding, which is the mass. What is the descriptor of this mammographic abnormality? How you are going to describe this abnormality? Just give me, what is it as a main abnormality? Is it
mass?
It is
Mass.
mass. It is a mass. Why it is a mass? Why you say it's a mass? Based on?
It has a conspicuous shade, يعني, it has a convex borders.
Okay.
Found in two views.
What? Yes, it has a convex border.
Yeah, it's found in two views.
Seen in two views, yes, excellent. Okay, what is the definition of the mass?
Mass is it's a 3D structure that
space occupying lesion.
Yeah, it's a 3D space occupying lesion.
Yeah, seen in at least two views. It has يعني convex border, and usually we find the mass more dense in the center.
Yes, and dense at the center more than the periphery.
The periphery.
Yeah, to differentiate it from asymmetry. So we call it as a mass because it's an space occupying lesion, 3 dimensions, one consistent shape in two different views, okay, orthogonal views, and it has a convex borders, and it is denser at the center. If you have seen a mass, there are 3 main descriptors required to evaluate the mass. What are these descriptors?
The shape and the margin and the density.
Excellent. The 3 descriptors as margin, shape, and density. What do you suggest to start with? It's better to start with which one?
Margin.
Shape.
Okay. Who said shape? Anyone, he said one descriptor, he should define himself. Why?
You said
margin
start with or the most important descriptor. What is the question?
It depends. It depends on you.
يعني
suggest one, your approach.
If you mean the most important, then I suggest the margin. If it is more the most important. But if
excellent, the margin is more important. Okay. All of you agree to start with the margin?
Okay.
Yes.
Do you agree to start with the margin?
Yes.
For me, I like to start with density. Why? Why I prefer to start with density? Do you have any impression about that?
If you say, for example, low density fat, then from the beginning you have يعني زي حسنة الأمر يعني.
Yes. If we start with density, if it is a fat containing lesions, then خلاص, no need to characterize it further. That is why I prefer to start with density, and according to the BIRADS system, the approach or the systemic approach to evaluate the mass is density, morphology including margins and shape, associated features, then the size and locations. Okay, this is a descriptor of the mass. So I prefer to start with the density. For me, I start my lecture with the density because the mass, it is either a fat contained mass or a radio-opaque mass. If it is fat contained and no any associated suspicious findings, then no need to go further. Then it will be antimony, one of the differential diagnoses, okay? And then it will be BIRAD 2. Otherwise, if it is opaque, then we will go further to see its density.
Okay.
If you look for this case, so you have a mass here, but the mass is completely radiolucent mass with the thin capsules. So we are dealing with BIRAD2 mammographic mass. No need to characterize it further. This is antimony. You see, it is one of the differential diagnoses, but the presence of these calcifications and another one here, so most likely representing oil cyst or a fat necrosis. Okay? Again, I'm dealing with large palpable mass, homogeneous, radiolucent with a thin capsule. Most likely it will be lipoma.
Lipoma.
Yes, a lipoma. Again here, I have a fat necrosis seen as a mixed fat contained mass. You see, lucent mass and central opaque. Here, this is in a case of, what do you suspect in this case?
Surgery, site of surgery.
Lipofilling.
What?
Lipofilling.
Lipofilling, excellent. Lipofilling. You see, a fat containing, benign, BIRAD2. And this, it is?
Hamartoma.
Hamartoma.
Yes, this is antimony, hamartoma, mixed fat containing breast mass. It is antimony, it is a hamartoma. No need to characterize it further. And what about these two cases? What do you suspect?
Also hamartoma.
Hamartoma, the first one.
In the left.
Which one? The first one, this or this? Left or right?
You are putting the
left.
mouse in, the cursor.
Hamartoma. And what about this one?
This is dense mass. Suspicious.
Can you see the capsule here? This is thin capsule, and there is a lucent line between the mass and the capsule. Not all hamartoma containing large amount of fat. It might contain microscopic even fat. It might appear like a fibroadenoma, but when after removal might be pathology discovered to be fibroadenolipoma, or MRI sometimes gives some characterization for tiny fat containing. The relations between fibroglandular to fat component is variable between mass and mass, or hamartoma and a hamartoma. These are both hamartomas or fibroadenolipomas. What do you think about this one? Also what?
Hamartoma.
But contain popcorn calcifications. It is the same like fibroadenoma. Hylamized fibroadenoma can be associated with popcorn calcification. It can also occur within the same component on fibroadenolipoma. But this is also radiolucent mixed density mass with popcorn calcification in a case of hamartoma. And this case, so also, not all hamartoma have complete capsule. When the capsule, here you can see the capsule, but the capsule here, it is incomplete. That is why it merged with the adjacent fibroglandular tissue. It is a breast with impressed appearance. But this is my case, and it was a hamartoma with a partial encapsulations. See? Here there is a lucency, and this is a fibroglandular component. But this is again a hamartoma. What about this one? This is just a mass behind the nipple, and it demonstrates fat fluid level.
Looks galactosele.
But she's not lactating. Look here also. يعني the multiple duct contain mixed densities. And this is also dilated duct contain mixed densities. So this is a fibrocystic changes. Okay? This case it was a fibrocystic. Also, she was my patients. So regarding the density, breast cancer masses are never radiolucent mass. Never radiolucent mass to be homogeneously radiolucent. It will never be a cancerous mass. Although it might be fat containing if the cancer, fat containing if rarely cancer arise in a hamartoma or cancer entrap the breast fat, you see, in a case of asymmetry or infiltrative process. Not a mass like, not real mass, but in a case of asymmetry or infiltrative process, it might entrap a fat within. So cancer can contain central or area of fatty or lucency, but not in a case of homogeneous mass. Okay, let us go for the next density, type 2 density, which is a radio-opaque. The radio-opaque, that means the mass doesn't contain fat. The whole mass appear as an opaque mass. And this is usually, okay, considered to be a predictor of the mass density here. It's considered to be predictor for malignancy. And how we measure this density? We measure it according to what?
Fibroglandular tissue, an equal size of the fibroglandular tissue.
Excellent, excellent. So we have, what are the types of density for the opaque mass? It is
high
either
density,
low density, okay, and the low density, but not fat. Low density, but not a fat density. The density is less than fibroglandular tissue. And cancer extremely rare to be visualized in this type or in this group. Equal density, historically called isodense, and the mass density will be equal to the same amount or same volume of fibroglandular tissue, has same attenuation, X-ray attenuation of equal volume of fibroglandular tissue, and the likelihood of cancer here is 22%. It will be in group, BIRADS group. How you are going to categorize this? The positive predictive value is 22. So it will be BIRADS
4B.
4B. It will be in 4B. And the high density, the mass is greater than expected attenuation of equal volume of fibroglandular tissue. And this is what usually seen in cancerous mammographic masses and is significantly associated with malignancy, with the likelihood is 70. So it will be BIRADS
4C.
4C. If you have a high density mass, only just to categorize, you see, the density per se without other features, If it is equal density, you will give it BIRAD 4B. If it is high density, it will be BIRAD 4C. Then look for the other features. Okay. Low density. This is here an example of low density, and we said that cancer is rare, and we consider it BIRAD 4A if there are other features here. And equal densities, we will consider it as BIRAD 4B, and definitely high density, it will be BIRAD 4C. Here we are giving the BIRAD category for the descriptors, not for the mass, because this is an speculated mass and a lot of things. But looking only for the descriptors. When we give the BIRADS is the evaluations for the descriptors of high or equal or low density. Okay. Here we have 3 examples of invasive ductal carcinoma. In this case, as usual, presented as a high density. But in this case, it presents as an equal density.
Equal density.
Still, this is an invasive cancer presenting as low density lesions, which is really unexpected. It is a rare findings. How we know that? Can you look here? This is same amount of fibroglandular. We compare it, definitely it is higher. Here, if we compare it with this area, it is more or less the same. It is equal. Here, if we compare the equal amount of fibroglandular tissue, it looks, this mass, it looks lower. What about this one? Here we have ductectasia, okay, dilated ducts, and this one, DCIS, and this is a simple cyst. How you are describe these masses regarding density? High, low, or equal?
Equal and high. Equal and high.
Okay.
Low in simple cyst, low.
Look for this one and look for this area.
Looks
low density.
Lower. And look for this and this amount of fibroglandular parenchyma. In this case, it is difficult because it is scared or little fibroglandular. But even if you look for part of the mass here, because here it is superimposed parenchyma, but this portion of the mass, compare it with this area, it is also low. So we are dealing with low density masses in different pathology, including cancer, DCIS. What about the density here? If we compare this with this area, it seems to be
low density also.
Lower.
Low density
and another
also.
mass here, another mass, retroareolar mass. This is also mass. It is lower than the adjacent parenchyma. In a case of, and even there is mass here, retroareolar. So what do you expect in this case? Do you expect certain pathology? You have the history.
Galactocele.
Galactocele. This lady presented 8 months after delivery. Bilateral lump. She has bilateral galactocele. This is low density masses. This is the same patient. This is the same patient after a time. She came for follow-up. Can you see? Look at this image, and this is the follow-up. So now it become, if you compare
Equal
it with
density
the
to the parenchyma.
huh?
Equal density. Equal
Equal,
density.
excellent. It become equal. So galactoseals can be lucent, can be low, can be equal. You see, there are variation. It depends on the component of the galactoseel. This is the same bilateral. Can you see the galactoseel here? This one I have shown to you here, but was not obvious. But look at it now. Here it become more clear, and this is even getting larger. So bilateral galactoseel of equal density, and this is ultrasound just to show it for interest. Ultrasound of the galactoseals, okay? Same patient.
Okay.
And what about this? What do you think regarding how you approach the mass regarding its density? You have 3 examples: simple cyst, fibroadenoma, and invasive cancer. What do you think about the mass density? How you are going to call it?
Equal density.
Excellent. This is an equal density. Previously, historically, they call it as isodense, but now they call it equal density when we compare to the same X-ray attenuation, of equal amount of fibroglandular parenchyma. And what about this? In this case, you have multiple masses, the largest and other multiple smaller.
High density.
The largest density.
The largest is high density.
Excellent. And the smaller are
ISO.
more or less
Equal.
Equal density. These are multiple cysts, and usually the cyst it look like that. Okay. And what about this? Here you have a papilloma, you have benign phylloides, and you have invasive cancer.
High density.
This is clearly so bright. It is high density masses. Okay. And this one, straightforward, it is a high density mass. Okay. So the predictive usefulness of the mass density in BIRADS lexicon remain controversial for long times. However, in the latest edition, they conclude that radiologists must evaluate the mass in terms of density and use it as descriptor to stratify the risk for malignancy. Okay, and the research has indicated that high mass density may indeed improve prediction of malignancy. And despite of these important clinical implications, still they consider it the least reliable than the morphology. Why? Because it is subjective evaluations. Some of you might say this is high, low, like that. It is subjective, not measurable. Not there is no, it is not measured by computer. Yeah. But because the 2D and overlapping breast tissue hinder that measurement. But there is suggestion that on tomosynthesis might be the density might be measured, or the optical density, it might be calculated. Also, if the breast is completely fatty, it will be challenging to measure or to relate to what. Or if you have minimal or smaller amount fibroglandular, not equal amount to the mass, it will be difficult, or the remaining fibroglandular is just superimposed by the mass. All these are challenging in evaluation or relation of the mass density to the adjacent fibroglandular parenchyma. And the large masses might also force, okay, to make comparison the basis of unequal volume of breast tissue and masses, as we mentioned before. And the majority of masses, they said, are isodense. Little are low or high density. However, in spite of these challenges, okay, in evaluation of the density, do not eliminate the value of the breast density as a predictor or indicator of malignancy. And here we can see some examples, okay, regarding the fat-containing mass, like hamartoma, lipoma intramammary, lymph node, fat necrosis, and galactoceles, mixed or homogeneous radiolucency. And here for the high density, like carcinoma, cystosarcoma phylloides, abscess, hematoma, and some type of cyst. The remain of the list of pathology, it will be seen in the equal density. Okay, regarding density, give a spot diagnosis from that list. So we give limited list of diagnoses for this group, huh?
Hamartoma.
Antimony. This is an antimony. This is a hamartoma. Fibroadenolipoma mixed. And this one.
Also.
Excellent. This is hamartoma. Look,
Hamartoma.
the capsule. This is the capsule and this is lucency. But the mostly the mass is fibroglandular component.
Yeah.
The fibroglandular component is much more than the fatty component. Here the fatty component is minimal. So this is a hamartoma. And what do you think this it could represent?
Also hamartoma.
Fat necrosis.
Hamartoma. Who said hamartoma?
Fat necrosis.
Yes. If you could not expect from the image, your history is pointing.
History.
Post intervention.
Intervention. history معناها fat necrosis. Okay.
Yeah, post intervention it will be fat. There is another clue. There is another clue
Fat necrosis.
of fat necrosis. What is that clue? Let me help you. I give you the this magnification view.
Presence of calcification.
No, there is not the calcification.
The capsule.
What is the clue?
The capsule.
Hamartoma having a capsule.
The high density in file. This low density region is differing in يعني in mediolateral is lower and in craniocaudal is in
what
the center.
What does it mean? What does it mean? The opaque ball is moving. Is moving within the cyst. Mobile ball. This is characteristic of fat necrosis. If you have seen this, give the diagnosis of fat necrosis confidently. This is antimony, okay? This is an oil. Okay, here you have 4 different cases of, what do you suggest? Also, if you have seen this, you expect to be what do you suggest?
Oil cyst. Fluid level. Fat fluid level.
There is one more characteristic than all cysts. Not unless it is acute infections or acute fat necrosis, it doesn't give fluid level. the old system. But this does not give appearance of acute inflammation and these things. Okay, so these are 4 different cases. For the breast.
سوري ده الكيس
Hmm?
دي نفسها. معلش دخلت وطلعت انا دكتورة رباب. الكيس دي شنو؟
Not
زي
yet.
اللي فيها fluid level.
I'm asking what could it be?
Okay.
4 different patients
Okay.
having the same pathology. You have lucent, homogeneously lucent, and you have mixed. And you have one with amalgamated. Okay? Amalgamated component. Look for the lucency in between. And here you have fat fluid level. What do you suggest? You have 1, 2, 3, 4, 5 differential diagnosis we mentioned. Is it a lymph node? Exclude.
No.
Is it a hamartoma? Is it a lymph node? Is it a hammer like that?
No.
What
For
are
me,
we
it is
making?
a galactosine.
Who said galactosine?
Galactosine. Galactosine.
Yes.
Fluid level.
This is character. Look for the breast itself. Look for the breast, how it is dense. This is a galactosile. This appearance is a galactosile. And what is the density here?
High density.
Based on what? You have, this is one of the challenges, okay? To measure the density or to relate the density because predominantly fatty breast. But you have a soft tissue here. It is denser than the soft tissue of the nipple. So, and denser than the soft tissue of the pectoralis. So, yes, it is a high density. This is a high density, and this is the same patient. Here it might give you a clue that this might be a fibroadenoma. It is a circumscribed high density mass. What do you suggest? What happened here?
Malignancy.
Tell me why there is difference. This is the same patient. How could you explain this appearance? Does it help you in the diagnosis of this case? What does it indicate?
Intervention.
Aspiration يعني.
Biopsy or like this from the mass.
Why you said aspiration يعني? Why you have to tell aspiration? The logic is yes. It is an yes. There is intervention. It is obviously here. There is effect of interventions. And what does it occur or what did occur after intervention?
يعني fat necrosis after intervention.
How come this mass turned to be a fat necrosis?
No.
No, the other.
It was a mass. It was a mass. And after intervention, it looks like this. Here it is homogeneous opaque. After intervention, it looks like mixed density. What do you suggest?
Hematoma.
If it is a hematoma, it has to get enlarged. The same, it is more or less the same size of that mass. What do you suggest? Hint, you said aspiration. What happens if they aspirate? So,
يعني
so this mass here.
أول شيء بدخل شوية اير وتاني لكن هنا اير ما ظاهر ما أعرف يمكن نورمال سلاين دخلوا معاهم.
They aspirate the fluid. They aspirate the fluid from the mass. This mass here, it is complex mass. It is a complex mass. They aspirate the fluid and demonstrate the wall of the mass as irregular with large mural nodule. Can you see it now here on ultrasound? Is complex cystic mass. As you know, the difference between ultrasound and mammography. The mammography is less specified than the specificity of mammography is less than ultrasound. Because the soft tissue, it will be opaque. The cyst, it will be opaque. See? But even one lesion on mammography, opaque lesion, it can be can be isocoid, can be hypocoid, can be hypercoid, can be mixed, can be on ultrasound. So this is, so from here, it is obviously, it is a cancer. And it was intracystic papillary carcinoma. You see, it appeared as a mixed density after interventions. So we discuss the density. Let us go for morphology as descriptors in systemic approach to evaluate the mammographic masses, starting by margins. What is the margin? What is the margin? The margin, okay, is the edge, border, or contour of the mass lesion. Okay, it characterized by what? But transition between the mass and the surrounding normal fatty tissue. Okay, it is as important as the shape, but even it seemed to be more important than the shape in predictions or as predictors to differentiate between benign and malignant. So regarding the margins, we have circumscribed, obscure in one side of benignity to microlobulated, distinct, indistinct, and speculated as a suspicious predictors or descriptors. Starting by this, can you tell which one? These lesions regarding the
circumscribed.
Circumscribed.
Yes, these are circumscribed. Why we said circumscribed?
I can see the whole margin clear.
Yes, abrupt transition. It is an abrupt transition between the contour or the edge of the mass and the adjacent fatty tissue, as if we penciling it. So, and it's completely surrounding by fatty tissue, completely. And if the mass not associated with calcifications, then the predictive value for benignity is between 98 to 99%. So the risk of malignancy is less than 2%. So we'll consider it BIRAD 3. Okay. This, the lesion, what we have seen now, it was a cancer. It was intracystic cancer, but it is circumscribed. Why? Because we have still, we mentioned that it was not 100% benign, circumscribed, not 100% benign. Still less than 2. We said less than 2 probability of cancer. Exactly around 1.4% of circumscribed margin mammographic masses can be a malignant mass. Do you remember the differential diagnosis of these malignancies? In this group, give me differential for the malignancies in this group. Do you remember, or shall I mention it for you?
Mucinous carcinoma.
Huh?
Yes, I know.
Mucinous.
Which group? The differential.
Mucinous carcinoma.
Excellent. Mucinous. Mucinous. What else? Go with M. Go with M. Mucinous.
Metastasis.
Metastasis. Huh? Breast metastasis. What else? Go with M still. Malignant phylloides. Phylloides. Malignant phylloides. Go with M. Medullary.
Medullary carcinoma.
M medullary. Metastasis. Malignant phylloides.
Mucinous.
Mucinous. And do you remember this? It was papillary. Okay, the papillary carcinoma, and also the high-grade invasive ductal carcinoma. Some of these group rapidly developing, okay, or rapidly proliferation concentrically, growing as a round or oval mass, okay, giving a circumscribe. No time to infiltrate, to invade, because it is rapidly growing. Not all invasive cancer, but some of high grade can be like this, especially triple negative. You might find some of triple negative appear as circumscribed masses. Okay. The second item or second descriptors is obscure. Which obscured? Do you remember the obscured and the difference from the circumscribed? If you look for the picture here, this is surrounding by fat throughout. This is part of the mass surrounding by fat, and part is obscured by the adjacent parenchyma. So to call it obscured, if more than 25% of the mass obscured by the parenchyma, then you will call it as circumscribed partially obscured. Okay? And this is a unique mammographic descriptors. It's not used for MRI or not used for ultrasound. Used only as descriptor for mammography masses. And if the mass at least 75% of its margin is circumscribed or clear, then it will be circumscribed. The circumscribed previously, historically, they call it well-defined or well-circumscribed. Now it is only the descriptor is circumscribed only, not well-defined or well-circumscribed. And the obscured, you can say obscured, or you can say circumscribed, partially obscured. And to say circumscribed, partially obscured, you need to see more than 25% of the margin obscured by the adjacent parenchyma. What is the margin of this mass? Where is the mass?
The lateral part of the breast.
This is the mass. We can see it is projecting from the contour as circumscribed, half of which is circumscribed, and half of which obscured by the adjacent parenchyma. So, yes, obscured. So this is obscured. Obscured, partially obscured. It is almost 50% obscured by the adjacent parenchyma or hidden by the adjacent parenchyma. So this is an obscure. Okay, let us go for another example. You see, it was a cyst. Can you see? This is the outer border, what we have seen here. And this is the deeper portion. Look for the parenchyma coming here, obscuring this portion of the cyst. What about this one? How we can call it?
Obscure.
Obscure, excellent. Because If we collect this portion and this portion here, it represents 25 or more. Okay, so then, and the remain is circumscribed. So again, this is, and this usually we have to proceed directly for ultrasound to further characterize the mass. This is an obscured, okay, and this also my case, you see, and it was complex. We recommend, we upgrade from probably benign to BIRAD 4 based on ultrasound, and the pathology was intracystic papilloma, benign. It was a benign, the outcome. What about the margin of this left breast mass?
Obscured.
Can you see part of which circumscribed? To say obscured, you have to have part of the mass circumscribed, as if you pencil it. Then the remain is obscured to call it as a circumscribed, partially obscured, because actually the obscured is circumscribed, partially obscured. Okay, so what about this one?
Indistinct.
Circumscribed? Huh?
Microlobulated.
Indistinct.
This is indistinct. Okay, and this one, again, it is indistinct.
Indistinct.
Look, can you compare it with the illustration here?
Yes,
The margins are not clear, no demarcation. There is no demarcation with the adjacent tissue. So part or the whole mass margin, if not clear, then we consider it as indistinct. Even there is part of the mass is indistinct, it might infiltrate through only part of the margin, not necessarily the whole margin. To be indistinct, to call the mass as indistinct, and this is the positive predictive value of which is 44%. And therefore it will be BIRAD 4B. And this case, it was cancer, but this case it was inflammatory cyst. So you have more or less half-half. Half are malignant and half, or slightly less than half as malignant, and the others are benign. And this margin here,
Indistinct.
indistinct, and look for
Speculative.
The
Speculative.
microlobulation.
Yes, the
Microlobulation.
predominant, there is subtle speculation. But if you can see it here, this is another example. This is more obvious than this.
Microlobulation.
You have multiple short cycles. You see bulge here, multiple. You see? That is why this is a microlobulations. Okay? And this is also suspicious with a positive predictive value of 17. This is also BIRAD 4B. Okay? And these both cases were invasive ductal carcinoma. And this one, this is very clear, obvious.
Speculation.
This is here, not always the speculations is very clear like this. It can be early and subtle. And regarding the speculations, there is difference in the literature. Some they are saying it is the positive predictive value in most studies is 89, because they mentioned that there is no single, there is no single descriptors reached by BIRAD 5. Okay, and they consider it as 89. But in other literatures or other studies, they said speculations, the positive predictive value of speculation reaching 96% or considered as BIRAD 5. Very few, okay, of less than 5% of speculated lesion represent a benign conditions. So it is almost always considered to be malignant. The highest descriptor of malignancy is the speculated margin. That is why the margins are the most important descriptors. So regarding the morphology, margins of the mass, the sign of primary importance, considered to be sign of primary importance, starting by probably benign descriptors include the circumscribed and circumscribed partially obscured. Okay, and as we mentioned, within the group of BIRAD category 3, because still we have 1.4% of circumscribed masses can be malignant. And the suspicious margins is due to tendency to invasive cancer infiltrating the adjacent tissue, resulting in either indistinct margins, which historically call it ill-defined. Ill-defined previously, in the latest edition, it is an indistinct. We don't know if they are going to change in the coming expected coming edition, 6th edition, or it will remain the same. And the other one is microlobulated, and the highest suspicious predictor of malignancy is speculated margins. Okay, let us go for the second descriptor of morphology, which is the shape.
Oval, round, irregular.
Yes, oval, round, irregular, and no more lobulated. Previously, they use the descriptor lobulated in the shape, but no more lobulated shape is used. It is either regular as oval or round or irregular. That is it. Okay, this is oval. It is obviously is an oval, elliptical or egg-shaped. Okay, they consider, because they are no more use the undulated or the lobulated. Here they consider few lobulations in the shape of oval, like this one. Here in these examples we have just one undulations, but in this here we have 3 undulations. Okay, 2 to 3 undulation, they consider it still as oval shape. Oval shape. If you have seen slight lobulations with large cycle, not a small cycle, yani not numerous, up to 3, then you can call it as an oval shape. Okay, no more lobular shape. Previously, they describe it as a lobular shape, but they take it away. No more use lobular shape. These are oval shape. This one, it is obviously globular, spherical, or the round shape. This is the round shape. And here, this one. Is it oval?
No.
Is it round?
No.
If it is not round or oval, that means it is not regular. Then we consider it as an irregular. Okay? And when you have an irregular shape, then you will consider it as a suspicious feature with a positive predictive value up to 73%. That means it is BIRAD 4C. Okay? It is a BIRAD 4. If you have an irregular shape, then it will be BIRAD 4C mass because of irregular shape. So the morphology describe margin and shape. As we mentioned, margin either regular, round, oval, or irregular. No more lobulations. The shape, I mean. Margins, circumscribed. Circumscribed, partially obscured, which is a unique descriptor for mammography in probably benign masses, and microlobulated, ill-defined and speculated in a suspicious group of masses. Okay, regarding the density, what do you suspect is mass?
High
How you
density.
can call it?
High density. High
This
density.
high, and you have another mass here.
Equal density.
Equal density.
Excellent, excellent. Okay, and here, again, the density.
Equal density.
Is it equal density? This is a magnifying view of this, and this is a magnifying view of this.
Okay.
High.
High density.
Okay. Think again and look carefully.
فيها center صح؟
In the center. Low density. Low density.
And look, this is a CC view, and this is the MLO. Where is the mass?
center.
Radiolucent.
Yes, it is in the upper outer, and it has a radiolucent center and a vessels coming nearby.
Lymph node.
Lymph nodes.
Oval. It is oval, circumscribed, small. This is typical, very typical. This is mixed density. Mixed density intramammary. Okay. Regarding the margin. Shape and margin for this mass. Shape and margin. Just shape and margin.
Round, obscure margin. Round shape, obscure margin.
Okay.
Partially obscure, partially circumscribed.
So, is not circumscribed, but what about the shape? Still, you will call it as round?
Irregular.
Now it is irregular. This is part of the mass. This is part of the mass. Yes, the shape is irregular. The shape is irregular and the margins are indistinct. Just margin for these bilateral high density masses. Why I said high density? Why I call it high density?
Comparing it with the muscles.
Fatty.
Compare it with the muscle.
Compared with the muscles and nipple are more higher, yes. So are high density masses. But just give me the margin.
Partially circumscribed.
At least, yes, these are circumscribed and partially circumscribed. These are bilateral cysts, multiple cysts, excellent. And the margins density of this mass.
Speculated.
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 Margin is speculated. What about the density?
Low density.
Mixed.
In the center.
Who said mixed? Who said mixed?
Me. Fatima.
Fatima, excellent. It is a mixed density, excellent. This is a mixed density. What is your differential diagnosis in this case? And the clue is in the image.
It could be fat necrosis.
Excellent, Suhair. This is a fat necrosis.
Fat necrosis.
You see, the patient have surgery.
Surgery.
Can you see here? This is skin irregularity due to surgery. Okay, and there are fat necrosis here, small. Okay, can you see here? These are fat necrosis. And look for the center here. It is more or less smooth like this, but still we cannot report it confidently as BIRAD 2. We have to go and evaluate it further. If we have previous to compare with, if we haven't previous, so we have to evaluate it to make sure that might be the previous location of excised
Cancer.
cancer, and there is recurrence in the same locations. So we have to evaluate it further and to make sure it is not
Recurrence.
it is not associated with recurrence, but this case exactly, it was a fat necrosis. Because fat necrosis is a mimicker, one of the common mimicker of breast cancer. So the mass we went through okay, give me 1 second. I want to check something. Okay. I don't know if I miss some of the image or the orders of the image. Okay. We said the mass will be characterized by morphology, shape, and margin, density. Then we will go for the associated feature, after which for size and locations. What are the associated features here?
Thickening and total nipple retraction.
Okay, so
Architecture.
skin thickening and skin retraction. Nipple retraction, but mainly here the skin changes in terms of thickening, retraction. Can you see the dimpling here? Skin dimpling. Okay, and this associated feature here is straightforward.
Skin thickening.
Skin thickening and trabecular thickening.
Trabecular thickening.
And here, the associated feature is
enlarged lymph nodes.
axillary adenopathy. Okay, malignant adenopathy. Associated features?
Skin retraction, skin thickening and retraction in the left one. The middle one, also skin thickening and retraction with malignant adenopathy. And in 3.
No, this is the nipple retraction. The associated feature here is nipple retraction. What is the associated feature in this case?
Microcalcification.
Excellent. Calcifications, the associated feature. So as you know, the associated feature either a skin retraction or thickening, skin changes, or nipple changes, nipple retractions, okay? Trabecular thickening, skin thickening, as we mentioned, axillary adenopathy, or the calcification or architecture distortion sometimes can be considered as an associated feature. Okay, so let us go for the size. If we look here, this is cancer and this is cancer. So cancer can be small, can be large. And the size is not a predictor for malignancy, but it is a prognostic factors. They consider it as a prognostic factors. The estimation is a basic in order to decide the type of the treatment for the breast cancers. And how to measure the size, it is important to have the longest axis of the mass. Not like that. Look for the longest axis. If it is obliquely, measure from the oblique and then come to perpendicular. If it is come from here, look for the longest. Take the longest axis and then perpendicular to that axis. We'll discuss it again later. And regarding the lymph node on mammography, just you will measure the short axis of the lymph nodes. Regarding the location, also we are going to discuss in the coming lectures, but just to have an idea, the mass, like other abnormality, we have to locate it, and the descriptors for locations is designing or designations of laterality. Is it a right or left quadrant, upper, outer, upper, inner, lower, outer, clockwise at 1 o'clock, 2 o'clock, 6 o'clock or so, and preferably to use both by quadrant and clock. And then the depth, it is in anterior, middle, or posterior depth, and the most constant and preferable measurement is the distance from the nipple. Okay, let us go to have an examples. Okay, we discuss all the descriptors of the mass and how to approach the mass. So we'll go through a lot of examples, okay, regarding or just to emphasize on these descriptors. This lady having a palpable abnormality, and this is the mammogram. How you are going to approach this mass?
It's
an
Over.
oval, circumscribed, mixed density, or containing fat density.
It is a mixed density or fat containing.
Fat containing density, yes.
So, so we
In
said
the outer,
usually antimenis. Antimenis is large, like that. So location, yes.
in the outer. In
Yeah.
CC, in the outer,
interior, just lateral to the nipple. Okay. Large. A mixed density mass. It looks like what? Look for the same of the breast.
Yes.
It is typical of breast within breast region.
Hamartoma.
Antimony. Yeah,
Yes.
here we don't need to say, since there is no associated suspicious findings, just I will say a large hamartoma. Mixed density mass with feature antimony to hamartoma. Okay, not associated with any suspicious features. So this is a hamartoma. This is a BIRADS 2. Straightforward. No need to say, to describe it more and everything. Since I say no suspicious findings, that is it. Okay. What are the most important mass descriptors? Just as a reminder, the most important descriptors are
margins.
Margin. Descriptors. We said not descriptor. We have important descriptors or less important descriptors. The most important are
margin and density.
Margin, density, and margin, shape, and density. These are the most important. And the less important, relatively, okay, less important, the associated feature, size, and location. Okay? Okay, let us go through examples. Regarding, before going to the examples, just to revise the morphology. Okay? Regarding the margin, we said circumscribed margins are representing BIRAD 3 and circumscribed partially obscured BIRAD 3. Indistinct BIRAD 4B. Microlobulated BIRAD 4B. Indistinct is more suspicious than microlobulated. And the most suspicious is speculated. It is BIRAD 4C وفي مقولة أخرى BIRAD 5. Okay, but at least just to know it as the most suspicious finding. And most of the time, you depend on the constellation of findings. Most of speculated masses are high density masses. And there are associated features. Then you will constellate the findings and then you will upgrade it to 5. And don't worry about BIRAD 4C or 5. Most of the time, it will be BIRAD 5 because you will add other suspicious features to the speculated margins. Okay. Regarding the shape, oval shape, BIRAD 3. But what about the round shape? Round shape, BIRAD 3, ولا 2, ولا 4, ولا 5, ولا what?
3.
So here.
Also 3.
Hint.
4A.
بتبقى more suspicious لما تكون round than over.
More suspicious.
Unless it is a cyst
لا
and you find it, a cyst on ultrasound, soft tissue round masses are not reassuring. If you have round masses, just being rounded is not reassuring. If you have a fibroadenoma, you have seen it probably fibroadenoma, but being rounded, don't call it as fibroadenoma. Don't give it BIRAD 3. Go for BIRAD 4A for rounded, upgrade it. And as you know, the irregular is BIRAD 4C. Okay, now it is clear. We can go through the example, okay? What about this one? Shape, margin, and density.
High density.
High density.
Oval.
Irregular shape.
Low density oval shape mass.
What?
High density.
High density. The density is high. The shape is oval.
Margin.
The margin
indistinct. Shape is irregular.
Look for the parenchyma. Here it is circumscribed, but here is obscured. But this is circumscribed, partial obscured. But being palpable, being high density, you are not considered. You will give it BIRAD 4, and then it was a mucinous carcinoma. We mentioned that circumscribed 1.4% of circumscribed mass margins, including the mucinous. Remember 4M. Remember 4M of the circumscribed margin. The mucinous, medullary, metastasis, malignant phylloid. These are 4. Then the
papillary,
specified, the other is specified. Now these all are specified. The other is specified is papillary. It's also in the group. And then the non-specified but high grade, non-specified ductal carcinoma, but it is a high grade. It is also some of which in the group. Okay, just you can this is one way to remember the differential diagnosis for circumscribed malignant differential diagnosis. Regarding the margin, For this one and this one only. This and this.
Circumscribed, partially obscured.
Partially obscured by what? Can you see? Here there is any parenchyma adjacent, this vessel or something, or one line coming
A
here.
lower border, I couldn't.
To say partially obscured, you need to see more than 25% of the margins, okay, covered by adjacent parenchyma. And to see the remaining of the margin is circumscribed. But usually for these small lesions, you need to have zoom or spot magnification. You have to have spot magnification to characterize, because these are too small. It is difficult to tell about the margins. Now look, though it is a fatty, but look, in spite of spot magnification, the density appear more brighter, even more dense. So these are small but are dense. And regarding the margin, what about the margin? Can you see the margin? Is it as you have seen it here?
No, indistinct.
Indistinct.
Indistinct margin and even subtle speculations can be visualized. So this is non-circumscribed, okay? So this compression with or without magnification is helpful to characterize these small lesions, okay?
Okay.
About the margin in these two cases?
Obscure.
We gave or we discussed many times the criteria for circumscribed partial obscure. Which one partial obscure?
On the left side.
You have number 1 and number 2. You can call according to number.
Number 1 partially obscure and number 2 is circumscribed.
Can you look carefully? Can you look carefully here? Okay. Only this area and this area. Can it consider this and this, consider it more than 25% of its margin?
No.
Less than 25.
Yes, so since less than 25, it will consider to be
Circumscribed.
And this is obviously because also here only small area here and here also less than 25. And what if I ask you to tell the pathology or to give a suggestion, pathological suggestion for this mass, what could it be? Considering this
calcification.
This layering calcification. So now you can say confidently, this is when I said layering calcification, so you are dealing with a cyst with milk of calcium. And this it was a fibroadenoma, okay? So both are circumscribed. Margin only. Straightforward, this one.
Destiny and
cured.
Huda?
Yeah.
What did you say?
Obscured.
Obscured, okay.
More than 25.
So if you said obscured again, Huda, the mistake. When we said obscured, we need to see the remain of the lesion, especially the portion projecting into the fat. This is projecting beyond the contour into the subcutaneous fat. Is it penciling? This portion is penciling. Is it circumscribed? Look at it carefully.
Indistinct margin with
Look for
spicules.
these lines. Can you see these lines? Can you see it now?
Yeah, yeah.
So?
Speculate.
Speculated.
This is speculated. Speculated margin. This is my case, and it was a cancer. Speculated high density mass, speculated margin, irregular shape even. Look, this is part of the mass. This part and this part. This and all these are spicules. These are spicules. Bent, but are spicules. 1, 8, and 2. Margins.
Try
I
one.
want to take many examples considering these descriptors. Descriptors, the important descriptors: margin, density, and shape.
One
The location and size we are going to discuss, and associated feature will be discussed further in another lecture. But regarding these more important descriptors of the mass, we want to take more examples.
On the right is circumscribed. On the left
Excellent.
is indistinct.
Excellent, well done. Yes. The margin, this one circumscribed, and this one indistinct. Both are my cases. The circumscribed was fibroadenoma, and the indistinct was cancer. Okay. So the shape of this
irregular shape.
Irregular.
Irregular.
Any other suggestion?
Irregular.
Irregular.
Oval.
No, irregular.
Rounded.
Who said oval?
Me. Oval.
Fatma, you said oval?
Yes.
Why?
3 lobulation.
Are you sure about these 3 lobulations? Are you sure this is not part of the mass? Are
No.
you sure this is not part of the mass? Are you sure something here part of the mass?
No.
This mass,
irregular.
because it is completely indistinct, it is difficult, although it seemed to be lobulated, or 3 lobules or oval shape, but because it is completely indistinct, you cannot tell that it is lobulated, so we will call it as irregular.
Irregular.
We will consider it as irregular shape. BIRADS 4C.
C.
You see, it might be a fibroadenoma, but still it can be cancer. Margin. Just margin. One word. When margin, either to say circumscribed, obscure, indistinct,
microlobulation.
Microlobulation.
Excellent, well done. This is a microlobulated. Just a microlobulated. Okay. More exercise. Margin.
Microlobulated.
Excellent. Microlobulated. Short cycles. Though here are too numerous, but still at short cycles and multiple cycles.
Okay.
Okay. And here, margins.
Microlobulation.
Is it a micro? Here you have 2 lobule only. If you look for the lobule, you will see this is an oval, because just you have 2 large lobule or cycles. But regarding the margin, can you see it as a circumscribed, as microlobulated, speculated, obscured, or indistinct? Which one?
Indistinct.
Indistinct. Excellent. Yes, it is
mixed
an indistinct.
speculation.
Yes, it is an indistinct because the surround look for the edema and the margin are not clear. Okay, and there is breast edema. And this one, the margin and density.
Indistinct margin.
Indistinct margin.
Equal density mass.
Density?
Equal density mass.
Equal. Excellent. Equal density, indistinct margin. Huh? Margin of 1 and 2.
One indistinct margin.
Indistinct. 2.
Indistinct. 2 partially.
Excellent.
Partially obscured.
Because here I can see circumscribed. And here I can see more than 25% obscured by the adjacent parenchyma. That is why I can call it as obscured. This is obscured and this is indistinct. Okay. So what about the margins of these 3 examples?
Margin.
Partially
obscured, partially circumscribed.
Take one by one. Tell me you are talking about 1 or 2 or 3.
When partially circumscribed, partially obscured.
Excellent. Circumscribed, partially obscured. Excellent. 1. Yes.
2 is circumscribed.
Excellent. Circumscribed. 3.
Indistinct.
Excellent.
Indistinct.
Look for the pathology. This, yes, it is obscured, but the pathology was invasive cancer. And this one, circumscribed, and it was fibroadenoma. And this one, indistinct, and it was invasive cancer. Shape.
Irregular.
Shape and density. Okay, shape. Talk first about, tell me the shape.
The shape, irregular.
Excellent, irregular. Density?
High density mass compared to the nipple. High
Yes,
density
high density
compared to the nipple.
Irregular and high densities, okay. Even for the adjacent parenchyma. And this one, shape and margin.
Also irregular shape. Margin is indistinct margin.
This combined, you can say indistinct. You can say speculated. Both are irregular and it is. Why we said speculated? Because usually we are taking the worst, the highest time, or the most suspicious. The worst suspicious descriptor, we use it. But sometimes we brought just to emphasize on certain this shape or margin. Take it as an example. But generally, if you have speculations, even partially, you can say just an speculated mass, or you can say combination of margin, of non-circumscribed margin. Sometimes the infiltration can occur, part of the mass become indistinct, part of the mass become microlobulated, part can be speculated, can infiltrate by different mechanism. Can you tell the shape of this mass? This is my patient.
Irregular shape.
Any other opinion?
Partially obscured.
Shape yeah.
Shape.
Shape irregular.
Any other suggestion?
وممكن طيب يكون oval إذا
Who's talking?
هي oval لكن يمكن بس عشان المارجن indistinct أو
That is why he brought it. It looks or it seemed to be oval, but spot magnification, spot compression, magnification view is usually helpful. Look at it now.
أيوة irregular.
irregular.
Different. Yeah, we mentioned before the benefit of the spot compression view. You see, we said is helpful in delineation. The margins of the or characterize the lesions much better than on the standard view. Here you can confidently say this is an irregular mass, though here it might appear as indistinct oval mass. Okay, so it is an irregular mass. And this one, density, margin, shape.
High density.
High density.
Margin is speculated. Shape is irregular.
Irregular, excellent. Why you did not consider this area as fat density?
بالنسبة لي زي الارتفاct. Looks like artifact.
Not necessarily to be artifact. You see, it can be necrosis. The density is not a homogeneous, not always, but we have to be logic. It is an speculated mass, you see, and this, it is a patchy here and here and here. So I'm not going to consider it as a mixed density. You see, I will take it as a suspicious mass, and just this is heterogeneous area. And look here, the area of probable necrosis where there are spicules, long spicules. This high density speculated margin, irregular shape. Excellent. So here, who is going to take this one?
Density, mixed density. Margin, circumscribe. Shape, oval shape.
Though the posterior portion you did not see, but it is
hamartoma.
Hamartoma.
Because it is a hamartoma. Yes, it is huge hamartoma, taking most of the breast. Yes. That is a hamartoma. What about this one? What about Sumaya? Did she join us or not?
Yes.
Oh, you are welcome, Sumaya. Since when you join us since the beginning or in the middle of the lecture or?
Middle of the lecture and the previous lecture I didn't got it up now.
Okay. So since you are not following since the beginning, it will be difficult for you. We'll give you less easy example. We'll give you easy example later by the end of the lecture. For all of you, density, high density, excellent.
Indistinct margin.
Indistinct margin.
Speculated.
And even speculated, subtle speculation is there. And the shape.
Irregular.
That is it. Just if you have there is left, upper, outer, 2 o'clock, high density, indistinct or speculated, irregular, mass measuring 1/2. That is it. That is the description.
BIRADS 5.
This is the BIRAD giving, you see, specific or the terminology. That is why it become more easy. Before, everyone describe in his own terminology. and the communication become difficult. But now, just try to apply these descriptors. Take more examples, okay? Be more confident about these descriptors, and just by phone. If you tell your seniors that you have, or even not your senior, if you tell just the clinicians by phone, this lady having I speculated high density regular mass, 2 centimeter maximum, or 3 centimeter, or 7 centimeter, in كده associated feature, so and so and so and so. خلاص, everything is clear. Even if you did not reach the BIRAD, he understands that you are talking about BIRAD 4C or BIRAD 5, according to your descriptions. And even for you, if you put proper descriptions, you will conclude to correct category. And accordingly, you will give the correct management. It will be much more easy and very quick. So, straightforward now. Density, obviously. Huh?
High.
High. Shape.
Irregular.
irregular.
Margin.
Margin. Speculated.
Indistinct and speculated.
There are some speculation is there. Since you have seen speculation, if you are not sure, you can say non-circumscribed margin. Combination. Between bracket combination. Non-circumscribed margin. It is non-circumscribed. Whatever it is speculated, indistinct, microlobulated, but it is non-circumscribed margins. If you are not sure. What about this one? Density. Compare it with here.
Equal.
Okay, but it seemed to be a little bit higher. No,
High.
you can pass it. Shape.
Okay.
Shape.
Irregular.
Irregular.
Margin.
Speculated.
Speculated.
Speculate. Associated feature. Not clear. So ask me. Because it is small lesions, just go for
Spot magnification.
compression magnification.
Spot compression.
Now it is high.
Calcification.
Now it is high.
Microcalcification.
It is high. Because
Density.
even here it is higher than on the standard view. On spot compression. If it is low density or equal, it should be lower in density, but now it is more brighter. Look for the adjacent pectoralis. You see? It is higher than the adjacent pectoralis. This is blurred image. And the associated feature is
Microcalcification.
Micro.
intramass microcalcification. And speculation now, it is so clear. So the associated feature intramass calcification or microcalcifications. Okay, so density, shape, margin, associated feature. This is a CC view, and here is the MLO view. So,
Irregular high density, speculated margin,
high
nipple
density.
retraction.
Excellent. Associated feature is
Nipple retraction.
only
malignant adenopathy.
a malignant adenopathy and possible
Trabecular.
yes,
This
there
is
is edema. There is
Edema.
edema, nipple retraction, adenopathy, and this might be other foci. Nobody knows. Just I have seen it now. Okay. What about this one?
This is
Okay.
High density.
High
Partially
density.
obscure, partially circumscribed, partially.
Excellent. Who said partially obscure? Circumscribed, partially obscure.
Here.
Excellent, Suhair. Yes, because if you look here, it looks circumscribed and this portion is obscure. It is the shape
oval shape.
oval shape. But look for the
إديمة
pathology.
إديمة البريست لكن البريست إديمة صح؟
We cannot tell it
But
is
partially,
no.
partially obscured.
The picture it is like
partially
that.
obscured.
Yes, this is obscured. It was malignant phylloides.
Okay,
This
partially
is one
obscured.
of the 1.4%. Do you remember the 4M? What are the 4M? Sumaya, did
Mucinous.
you attend with us the 1.4% circumscribed malignant lesions?
No.
Okay, so here, can you tell us what are the differential diagnoses of circumscribed malignant masses? Those, Sumaya,
Mucinous carcinoma.
we said the circumscribed borders is 98 to 99% benign masses presented with circumscribed margins. If we have seen a circumscribed margin, we expect to be benign. But since it is not 100%, it is only between 98 to 99, so less than 2% probability of cancer, it will be within the group of BIRADS 3. So if you have a circumscribed margin, you will characterize the circumscribed margin as descriptor. You will consider it as BIRADS 3. BIRADS 3. But so we have 1.4% malignant lesions having a circumscribed margin. So here tell us what are these malignant masses can be presented as circumscribed margins. يعني simulate the benign masses on mammogram.
Mucinous carcinoma. Medullary carcinoma.
Mucinous cancer.
Mucinous.
Medullary.
Malignant phylloid.
Malignant phylloid, like this example.
Metastasis.
Just يعني we put it in a way to be easy to remember it. We said 4 started by letter of M. The mucinous, the medullary, the malignant phylloides, and metastasis started by M. So remaining two.
Papillary.
Mucinous and medullary are specified types of ductal carcinoma. So there is another specified, which is
high-grade invasive ductal carcinoma.
No, just we try to put in categories to remember it. We have still the papillary. The papillary as
papillary
type also it present as circumscribed. So the specified type of ductal carcinoma can be presented as circumscribed, which are 3 of them or 2 of them in group of M. And the third one is the papillary. Okay? And then remain is the ductal carcinoma itself. The high grade of ductal carcinoma, there is no time to infiltrate, to invade. So it will grow rapidly in concentric way as oval or rounded. We said, especially like triple negative or those high grades or other even high grades, it can be presented as circumscribed. That is why we have to be cautious when we categorize a mammographic mass. And that is why now they concentrate on the density of the mass. Very unlikely this mass to be of lower density, circumscribed lower density. And even we have to consider if the mass is palpable. If the mass, the lady presented with a recently palpable abnormality, we should not label it as BIRADS 3, even if it is circumscribed or equal density. Okay? Oval, circumscribed equal density, but recently, palpable abnormality, we have to go further and characterize it further. You got it? So this case is circumscribed. We consider it as circumscribed, partial obscure, but still it is high density. It is oval, but it is high density. We will not consider it as benign. We will not report it as BIRAD 3. We'll raise it to BIRAD 4. Okay, at least BIRAD 4A, at least. Because of that. And even I will not go for BIRAD 4A. Why? Why? We said the high density mass will give it BIRAD 4C.
C.
We'll give it BIRAD 4C because of high density. So we'll give it BIRAD 4C and we'll recommend biopsy. And then it was a phylloides, malignant phylloides tumor. Okay, this regarding the density.
High density.
High.
Density.
High density.
Irregular
Margin.
shape. Speculated
And
margin.
this.
Speculated margin.
Speculated and irregular shape. Regarding the associated features.
Trabecular thickening. Nipple retraction.
That is the nipple, but I will consider it, I will accept it. This is the areolar skin. Focal skin thickening or skin retraction or areolar skin retraction. It's okay. There is retraction. And this is here asymmetry. But at least this one, it is associated with this retractions. Okay? And area of asymmetry. Okay. So number 1 and number 2.
Equal density. Irregular
Which one?
shape. Number 1. Equal density.
Okay, if I ask you to compare the two regarding the shape.
Irregular shape, oval shape 2. Irregular 1.
This is not an irregular. This is also oval.
Oval.
Both are oval shape. But what about the density?
One
the density
one.
of one is
high density.
High, and
high density.
two
Equal.
Excellent.
Equal density.
Two equal density, one high density. Margins.
Speculated. In one.
Which one is speculated?
One.
And two?
Circumscribed.
But this is not unspeculated. This is, you see, I have to bring, this is indistinct. This is the parenchyma. There is edema and the parenchyma here, there is inflammation. This is an inflammatory cyst. Both are mycelia. This is a fibroadenoma and this is inflammatory cyst. That was inflammatory cyst. And this is edema, because there is edema surrounding the cyst. That is why it become, there is some thickening of the trabeculation. This is not speculation of the lesion, but thickening of the trabeculation secondary to the perilesion edema. Okay? Margin is straightforward. Sumaya, what about the margin in this, in 1 and 2?
Speculated.
Excellent. Speculated margin. Excellent, well done. Margin, density, shape.
Shape, round, density, high density.
High density, round shape, and margin.
Will subscribe.
circumscribe. Yes, previously the descriptor was well defined, but they said don't say well circumscribed or well defined. They changed it to just one word, circumscribed. So this is circumscribed, but it is high density and rounded. So it will be BIRAD if I ask you to give it BIRAD. So you will give it BIRAD 3, 4A, 4B, or 4C?
3.
Huh?
4A.
4C.
Okay.
4A.
4A, defend yourself. Defend yourself. If you said, you give it, you categorize in certain category, just define yourself. Who said
Circumscribe.
3?
Yes.
Density.
One minute. Who said 3? Sumaya. Tawan, yes?
3 because high density will define or round. So we'll give by X-ray plus ultrasound correlation. We may increase the ultrasound.
I will not give it 3. You did not attend the discussion. Just wait and concentrate in this case, okay? In the discussion of this case. Who said BIRAD 4A?
Me. 4A.
Define yourself.
Circumscribe.
Or defend yourself. And since I said define. Defend yourself. Sorry.
Okay. Round and circumscribe. Go with benignity. High density. Round and circumscribe.
Okay. We said circumscribe. Circumscribe is
benign.
BIRAD 3. Circumscribe is BIRAD 3. Okay.
Yeah. Round is
BIRAD. Huh?
BIRAD 4.
Yeah, okay. So with round we will upgrade it.
Yes.
With
Density.
round, upgrade it to BIRAD 4A. Okay.
Density.
Density.
It will raise the upgrade. It will be 4B.
It will get a density. We said equal density is BIRAD 4B. High density is BIRAD
4C.
Even associated with benign, with other benign feature. It is associated with other benign feature. High density, okay, but it is circumscribed and
we said, but being high density, we'll give it BIRAD 4C.
4C.
From the start,
we'll go for ultrasound. We said unless ultrasound demonstrated as a simple cyst, it will be a suspicious. By mammography, this lesion by mammography is BIRAD 4C. That is why they gave each descriptor, they gave it a BIRAD label. You see? So according to the descriptor, put your BIRAD. Then you can upgrade. Then we'll go for ultrasound. If you find on ultrasound this lesion is a simple cyst, then we'll downgrade it to 2. We'll downgrade it. If we find it a complicated cyst, we'll downgrade it for 3. If we find it a complex cyst or a soft tissue, then we will go for biopsy. We'll leave it as BIRAD 4C. If we find other ultrasound suspicious feature, we might upgrade it to 5.
And has any mass with high density, it is BIRAD 4C.
Yeah, it should be.
Okay.
It should be BIRAD 4C. Being high density, it is BIRAD 4C. So this case, It was circumscribed medullary carcinoma. You see? That was the diagnosis. Look, this is one we have seen papillary, we have seen mucinous, and we have seen medullary. The three, and we have seen malignant phylloides.
Malignant phylloid.
Just remain from M, remain what? The metastasis.
Metastasis.
High grade. Okay. So this is one of the 1.4 circumscribed malignant lesions. Okay? This, the margin. Sumaya, the margin here?
Yes.
Huh?
Yes, yes. This is before you said still in the start of the lecture that you are 3 lobes, more than 3 lobes.
I could not recognize what you are saying. Look for the margin of this mass. Tell me.
Partially speculated.
Since you have a speculation, that means we said we have to take the worst sign, or the highest suspicious sign. So, since you have a speculation, you will consider it as
BIRADS 4.
Speculated mass. Just our question is margin. Just we will consider it as being speculated mass. It will be but being speculated, regardless of other descriptors. It will be at least BIRADS 4C.
So,
at least, if not BIRADS 5. Okay. And this? Yes, I'm asking about the margins. 40-year-old lady presented for a baseline screening. Okay?
So BIRADS 4C.
Excellent. It was BIRADS 4C because the margin is
indistinct.
Indistinct, and you have some. Look for
speculation.
this area of
speculation.
In spite of this speculation and these things, and even high density, it was biopsy proven fibroadenoma. That is the breast. Unpredictable. Unpredictable. But we have no problem. We have no, just regardless of that, you see, we are going to just recommend biopsy for us. In spite of this, since now we have seen fibroadenomas and this is the speculation, but at the end, we are going to recommend because of this, still we consider the mass as, regardless of these findings, we are going to considering the speculated mass as they describe it as at least BIRADS 4C. Any speculated mass, we have to call it BIRADS 4C. Even that one of fat necrosis, we have to consider it as BIRADS 4C and further evaluate the mass even with tissue diagnosis to say this is a fat necrosis. Density, shape, and margins.
Equal density, partially circumscribed,
look for this tissue. Look for the
fat.
This is the
fat. Fat contain
fat. This is parenchyma. Look for this parenchyma. This is the parenchyma. It is high density. Consider the adjacent tissue. It is higher, because that is a duct here. This is different, but this is the parenchyma, so it's considered high. So regarding the shape and margins, tell me the shape and margins.
The shape is oval, margin partially circumscribed, partially obscured.
Okay, this is your suggestion, Another suggestion?
Circumscribed. Few indistinct.
Indistinct, yes, partial indistinct. Yeah.
And what about the shape?
rounded. The shape is rounded.
And what
هنا
about this?
irregular shape.
Yes. It's
Irregular.
irregular and indistinct. And if you can consider this single spicule, but at least it is indistinct. It is indistinct margin, is high density and irregular shape. These are deceiving part of type of masses. You see? Huh? Just margin.
Microlobulation.
Excellent. Multiple short microlobulated density is high. Okay, that was invasive ductal carcinoma, and it is a microlobulated. That is my case. This example is mine.
Indistinct margin.
The mass projecting into subcutaneous fat. Look for this portion in the subcutaneous fat. How does it appear? I did not bring, let me make for you now you I make it I burned the case. I tried to bring for you
we are
zoom
not
view. But even without
we are not see what is the case. Go. We are not see.
No. Even if I go back, you can see it. Or you will see it.
I mean go.
ما شفنا حاجة حتى الآن.
Okay, no problem. Look for the marking. What about this margin? You consider it as what?
Circumscribed.
This is circumscribed. So you have circumscribed, and this is projecting into the parenchyma. So this is will be circumscribed, partially obscure. It's same like the previous cyst. Okay, but with this, a lot of lobulation you don't expect to be, or we don't expect to be a cyst. But on ultrasound, it was a soft tissue. So we recommend biopsy. And it was a fibroadenoma. This is obscure. Yes, it is circumscribed, partially obscure. But because it was atypical, the lobulation, look for the lobulation. It has a little bit more lobulations. It was a biopsy-proven fibroadenoma. For me, any atypical fibroadenoma, I recommend biopsy. Recommend biopsy. I'll not give bariatric. I'll give the patient benefit of doubt. Okay. Density, shape, and margins.
Hamartoma.
Excellent.
High density.
Excellent. This is a hamartoma. Straightforward. This is a hamartoma. Antimony. Okay. Margin.
Speculated.
Excellent. Speculated and microlobulated. That is melanoma metastasis, this case, and it has both speculated and microlobulated combined. Margin.
Indistinct.
Indistinct, yes.
Yes. Here it is more obvious. In the zoom view, it's more obvious. Yes, it is irregular shape and indistinct margin. This is telling that I am
speculated.
This is very typical. Very, very typical speculated mass. And what about this margin?
Speculated.
Though are less speculated, but typically speculated. And this is also showing that I am speculated.
With nipple retraction is cancer.
Okay, what about this one? 1 and 2.
In the one it is the fat containing lesion. This is hamartoma.
No, it is
Circumscribed
not
margin.
hamartoma. So here you cannot see, yes, you can see halo, surrounding halo, but there is no capsule beyond the halo. There is no capsule.
Circumscribe partial obscure.
Excellent. And this one?
High density.
Circumscribe, high density.
Circumscribe. When we talk about the margin, both are circumscribed. One is circumscribed, one circumscribed partially obscure. Regarding the shape?
Round shape.
Rounded.
Round
Both
shape.
rounded.
So, unless ultrasound reveals simple cyst, will not be happy, will not be relaxed, will not take it as just this is a benign and so on. No, both are round, circumscribed, partially obscured, as you mentioned, and this is circumscribed. Okay, that was a simple cyst, and this was a fibroadenoma. Biopsy proven. So they recommend biopsy. This is because on ultrasound it was a simple cyst, downgraded to 2. But this one, because it was soft tissue, they recommend biopsy, and pathology was fibroadenoma. Margin only for this.
Speculated.
This is speculated. Margin.
Indistinct.
If you look carefully, you will see subtle speculations. Can you see it? Can you see these spicules? Can you see this spicule? Here in the zoom view, شايفها? These are spicules. It is speculated. And this one. That is a lesion here. This type of parenchyma that I hate. Look for the lesion here.
Speculated.
It's also speculated. The lesion in which side? In this mammogram?
In the right.
On the right side.
Margin. Right. Agree.
Right. Circumscribed, partially obscured.
Excellent. Well done. Excellent. Yes. That is the halo. You see, that is the halo. This is circumscribed, partially obscured. Circumscribed. Density, margin, and shape. So,
fat density. Mixed, fat containing.
Predominantly fat.
So,
hamartoma.
So you have seen various type of hamartomas. What about margin, shape, and density of this mass?
Indistinct.
You can see
indistinct margin.
Indistinct margin. Excellent. So, and the density?
Equal.
Excellent. Equal density. Yes. Then the shape?
Shape irregular.
It can be irregular, but they describe it as a rounded. You see, they said it is a rounded, but I accept being indistinct. I accept irregular shape. Okay, so that is its ultrasound. Here it is a microlobulated on ultrasound, and look for how it is highly metabolic on PET scan, how FDG uptake of the mass on the highly active. This is a malignant mass, so obviously,
hamartoma.
Excellent. This is antimony, hamartoma. Density, margin, shape.
density,
oval shape,
high density,
high density.
high density, huh?
lobulated
shape
margin,
oval, excellent shape oval. طيب margins,
lobulated margin,
huh?
microlobulated margin,
Microlobulated. What are the short cycles?
partial obscure.
Circumscribed
Yes,
partially
it is
obscure.
obscure. It is indistinct. Look at it here. Even if you look for where there is a fat, it is not يعني as sharp as circumscribed. You see, it is an indistinct. It is oval. It is high density, and it was a cancer. It was a case of cancer. Okay. And what about this?
high density,
High density.
circumscribed margin,
Circumscribed.
round shape,
Round. So it is BIRADS
4C.
4C,
4C.
4C.
And it was a cancer. This one it was a fibroadenoma. Okay. What about this?
high density,
Same.
round
It looks the same as previous. High density, circumscribed. One is rounded, one is oval. But these are papillary cancer. Can you see this and this?
Same.
See, more or less the same.
The same, yeah.
Same. This one, it was a fibroadenoma. And these are papillary carcinoma.
Okay.
What about this? Two examples. Oval, high density.
left, high density.
Both are high density. Oval, high density. What about the margin? It looks...
Margin circumscribed.
Huh?
On right, circumscribed.
On right, what?
Circumscribed also.
Yes, it looks circumscribed, but there is some difference between the two. Can you look here? When we say circumscribed, look carefully. If it is penciling, it will be sharp border, as if you brought a pencil and draw the contour of the mass. And there is another, okay, circumscribed, but with fuzzy, yani unsharp border, like this one. Look for the margins. This is yani not very sharp, not sharply defined circumscribed. It can be circumscribed, but with unsharp border. You see, with unsharp border, it seemed to be circumscribed. From far, you will say this is circumscribed, but when you magnify it, the border, it appears fuzzy. Yes, it is not, the shape is regular shape. That is why I give you an impression that it is yani, a circumscribed. But if you look carefully, you will see the margin fuzzy, and these types, yani, most of the 1.4% of circumscribed, you will see it in this group. You will find subtle fuzziness in the borders. So again, in this time, remember, Sumaya? Are you there?
Yes.
Okay, give us the differential diagnosis of 1.4 as a reminder. We brought it again as a reminder so as not to forget. What are the 1.4% groups of malignancy presented as circumscribed margin?
Mucinous carcinoma.
Mucinous, excellent.
Malignant phylloid.
Malignant phylloid. Another 2M. Mucinous, malignant phylloid, metastasis, and medullary. And remember, since you said mucinous and medullary, remain the papillary. Remember the papillary. So it will be the papillary. And then the high-grade invasive ductal carcinoma. We said it has no time to invade the surrounding parenchyma. Then it is just, okay, will concentrically grow. So you'll see the circumscribe. But when you go in this group carefully, make a spot compression, you'll find the margin as a fuzzy border. You will not see it as penciling a circumscribe of a benign lesions, okay? Most of the time. What about this, ya Sumaya? Density, margin, shape.
Density high, shape rounded, margin
Don't rush. Take it one by one and look at it carefully. Can I show you this one? What about this one? The shape of this one is?
I'm talking what you talk about what I didn't saw the cursor.
Here, can you see?
Yes, I'm talking about another one. Yeah.
I'm talking about the three at the same, but take this one.
This one. The high density compared to
What?
the high density.
Why you take high density? What about this one?
It's fat.
And here.
It's also fatty.
Okay, so we call it as
Mixed.
Density.
Mixed.
Yes, this is mixed. This is fat contained. And this is the same. This arrow pointing for the, it looks a little bit fainter, but it is the same. The margin is?
Margin will circumscribe.
Circumscribe, excellent. And then the density will set mixed density. If it is fat containing, we will not say high, low, or like that. If it is mixed density, then we'll take it as fat containing lesions. And the shape, oval. Yes, this is rounded, but these both are oval. Margin circumscribed. So are small. Where exactly? This is MLO and this is a pectoralis. Some vessels coming here. So, and again here, adjacent vessels. So what could it be? This is antimony.
Oil test.
These are antimony.
The
outer quadrant is small, less than 1 centimeter, mixed. The fat density at the center.
Fat necrotic or oil cyst.
Okay, other suggestion?
Intramammary lymph nodes.
This is a typical for intramammary lymph nodes. These are the typical for intramammary. For this, I will confidently say this is intramammary. But for this one, I will go for ultrasound to make sure it has the typical features of intra, because it is not very typical. This one is not typical on mammography. But this one, these two are typical intramammary lymph nodes. Okay? Okay. Tell me the margin shape and possible associated feature.
Indistinct margin.
Okay.
The shape is irregular.
Irregular. Excellent.
In the left associated
margin non-circumscribed. Microlobulated and indistinct combination. Can you give associated features?
Microcalcification.
Calcification. And what else?
Edema.
Look for this band going to, and look for the nipple. Nipple retraction. Okay. Okay, can you see? I told you microlobulated and speculated. Can you see the speculation more obvious on ultrasound than on mammography? But here, at least the microlobulations indistinct and some speculation are there, and this band going toward the nipple with nipple retraction and microcalcifications. And this,
high density, indistinct margin,
excellent,
irregular
excellent,
shape.
high density.
Indistinct margin,
Indistinct margins. Okay.
irregular shape.
Irregular shape.
Excellent, well done. Though they consider it as oval, but to me, I accept irregular. Okay? Can you see it on ultrasound? It is irregular. This is from literature. These cases are from literature. I brought their descriptions, but they consider it as oval, but it looks, because of this indistinct margin, I cannot confidently say this is an oval. I will go for irregular, and even here on ultrasound, it looks highly suspicious, irregular, and even this is the associated axillary lymph node. You see, it's suspicious axillary node, and it seems to be malignant. So now I think you just 3 words. Huh?
Speculated high density.
Speculated high density,
Shape.
irregular, speculated high density, irregular mass.
And
Like
it
that.
is site, and it is site. Okay, also is. It is site.
The associated features.
Extension into the
Excellent. Suhail. You said what? What did you say?
Invading the pectoralis muscle.
Yes, invasion of the pectoralis, tethering. Okay. Not separable from the pectoralis with tethering. It's pulling the pectoralis. Indicate that it is infiltrating the pectoralis. Tethering and retraction of the pectoralis muscle, that indicates its invasion. This is here one of the associations. Okay, what about the density, margin, and shape?
High density, speculated, irregular shape.
Excellent.
Irregular shape.
Yes, it is. But the density, it is equal density. It's not a high density, because this is part of the parenchyma. This is equal amount of the parenchyma. It looks more or less the same as this part of the parenchyma. It is equal density, but it is irregular, indistinct, and speculated. So, because we'll take the worst. Irregular shape, BIRAD 4. For what?
4C.
Okay.
4C.
Equal density, 4B. But this is 4C. Indistinct, 4B. Speculated margin, 4C. Being irregular shape and speculated margin, I'll go for 4C. I'll go for 4C. Why? Because it is equal density and it is still small and no other features. I will just give it BIRAD 4C in this, to weigh the things. Okay, so now we can conclude our talk. What is the mass? As we said, it is a 3-dimensional lesion, space occupied, seen in 2 different mammographic projections, which appear with a consistent shape in these projections. Its center is high density and the borders partially or completely convex. And the mass characterized by its density, shape, and contour. It could either be fat content or opaque. And as we mentioned, the density is significantly associated with malignancy, despite of important clinical implication of density, but is still considered to be the least reliable mammographic features, not like the morphology. And the mass was less used than the morphologic descriptors, and it's associated with many challenges, as we mentioned, is not computerized measurable on 2D because of overlapping tissue. It is just subjective evaluation, and it is difficult to be evaluated in completely fatty breast, among other challenges, but still suggested that to more use the mass density as descriptor, as a mammographic descriptor, to improve its evaluation and to be with more consistent. And regarding the margin, the circumscribed mass, most of which are benign or almost all benign, up to 99%, while indistinct microlobulated speculated margins are suspicious, having varies positive predictive value of malignancy reaches about 89%, and in some other literature up to 96% of it for the speculated descriptors. And the use of spot compression, as you have seen, how it helps us in further characterize and precisely analyzing the shape and the margins of the mass. And the size of the mass is independent, significant predictor for malignancy. However, the mass should be measured and located. And thank you very much for your patience and your contribution in the discussion. I hope it was beneficial discussion and you enjoy the time with me.
Thank you, Rabat. Thank you. Stop recording.
Welcome. Welcome. Any question regarding that discussion? Sumaya, could you follow that after we mentioned the conclusion of the lecture? Could you follow the descriptors?
I follow, but I need to see the previous lecture. Really?
No, this one is relatively independent from the previous.
But
here, just here we start by the we said we start by the abnormal. We mentioned before, we mentioned that we are going to start the mammographic lexicon interpretation of evaluation of the mammography or interpretation of mammography based on BIRADS lexicon. Okay, and as you know, the lexicon, the report that they have a formatted report. Formatted report started by what? We have to write the indications or describe the indications and the mammographic density. This is this part we discussed the last lecture. And then the third item is to describe the abnormality. And we start the abnormality, we said the abnormalities, the descriptors for the abnormality are mass, asymmetry. What?
You hear me? For me, I need for the problem for me when I said irregular, when I said circumscribed, what the shape, what's this the shape? How can I say this is microlobulated macro, something like this? So that I need to see the previous lectures and I will follow, inshallah.
No, you mean the early part of this lecture.
maybe I can
early
نبعت
half because we describe all these.
Rabab, stop recording, please.
Okay.